shoulder instability from overhead movements and overuse. On January 17, 2010, the athlete fell on an outstretched arm with another player on top of her and dislocated her shoulder. So on the initial evaluation, the athlete stayed down on the court and was in extreme pain. So during the evaluation, the shoulder shelf had shifted downwards compared to the left side, which was what initially made us think that it was dislocated. The head of the humerus was also palpated in the axilla. Active and passive range of motion in all planes was extremely painful, and so we diagnosed it as an anterior shoulder dislocation. Because it was an anterior shoulder dislocation, she was splinted with the triangle sling and referred to the hospital immediately for reduction. So, like I said, she was put into a triangle sling and sent to the hospital. Before sending her to the hospital, we checked for capillary refill and sensation just to make sure that was okay. At the hospital, she got a pre-reduction X-ray to make sure that there was no fracture before reducing the shoulder. And then once it was determined that there was no fracture on any of the bony structures, the physicians reduced it using Milch's technique and then packed it with ice packs to decrease pain and inflammation. Milch's technique involves having the patient lying on their back. One of the physician's hands guides the humerus back into place, while the other hand abducts and externally rotates the arm. This relaxes all the muscles of the rotator cuff, and then it makes it a little bit easier for the humerus to be guided back into place. This technique was chosen because it has a very high success rate. There's also a low complication rate, and it usually does not require an anesthetic for the patient. After the dislocation was reduced, the patient had a post-reduction X-ray and MRI to make sure that nothing fractured or tore during the reduction, and it was during the MRI that the glenoid labral tear was discovered. So the patient was advised to surgically repair that tear, and then they were immobilized in adduction and external rotation. While waiting for surgery, the patient Isdalian had to decrease inflammation and swelling, and also did inferential current. So the surgery, they chose to do arthroscopic repair with suture anchors. It was chosen because it's less invasive and it's easier to obtain a full range of motion as compared to an open procedure. The anterior labrum is debrided and shaved down. All the extra gunk in there is removed, and then 3 middle sutures repairs the tear. Here's a little picture of what a normal labrum looks like, the tear, and then the anchor bone, the sutures, and then the 3 middle sutures once they've been put in. So the surgery is scheduled for January 26th, which was within 10 days following the initial dislocation, which is recommended. The patient was immobilized following surgery, and again, adduction and external rotation. Pain and inflammation were monitored every day, and then rehabilitation was started on the 28th, which is 2 days, and that's again just the basic modalities in ice with light and motion. So the rehab process was broken into 4 stages. There was the acute phase, early rehabilitation, late recovery, and functional recovery. We also implemented psychological techniques throughout. So phase 1 is the acute phase. It was 2 days following surgery to 3 weeks post-surgery. So the goals for this phase were to decrease pain and inflammation, strengthen posture and soft tissue structures in the shoulder complex, begin increasing active and active-assisted range of motion, and then incorporate workout progressions for cardiovascular fitness on the stationary bike, as well as core exercises to stabilize the joint. So criteria for progressing from this stage was the pain had to decrease from an 8 to 3, and we did this by checking in with the athlete daily to see where their pain was at on a scale of 1 to 10. The range of motion just had to increase, and this was checked on with goniometry measurements. Swelling and inflammation had to disappear from the shoulder, and the patient had to be able to bike for 20 minutes at 60% effort with their heart rate and their training target heart rate according to the carbon information. So some examples of things done during the acute phase were electric current stimulation therapy, or IC, isometric holds, scapular squeezes, jogging, circumvention, stationary bike. The next phase was the early recovery phase. The goals for this phase were to increase range of motion flexibility, increase strength and endurance. So to be able to progress from this phase, the athlete needed to be able to complete 3 sets of 12 repetitions for each exercise that they did, and they needed to be able to move through range of motion, which is not there. So some exercises done during this phase were the UVE bike stabilization exercises on all fours with the fast forward, internal external rotation with a TheraBand or with a dumbbell on their side, rowing, wall washes, push-ups, bend over rolls, scratching with their thumbs up or thumbs down. And then I've seen expert continued here. We also started doing joint mobilizations to mobilize the joint. Phase 3 was a late recovery phase. It lasted between weeks 6 and 13. The goals for this phase were to reestablish a full range of motion and increase strength, power, and endurance. In order to progress from this phase, the athlete needs to be able to have a full range of motion and 70% of the original strength, power, and endurance. Some examples of exercises done during this phase were cat and cows, a core-based program, push-ups, push-ups on unstable surface, supine-rooted ball toss, standing ball toss, and ball toss against a plyo back. Phase 4 was functional recovery. The time for this phase was 14 to 16 weeks post-surgery. Goals for this phase were to increase strength, power, and endurance to support basketball because that was their sport. Criteria for returning to play were to be able to perform functional skills at 90% speed without pain. Phase 4, functional recovery. Some examples done here were jogging, floor range of motion, core, sport-specific drills, and such as box jumps, sprints, ladder drills, and 5-block drills. So in order to return to play, we checked to make sure that there was little to no pain with all activity. There was normal to near normal and ranges of motion, normal to near normal strength, normal functionality, and normal sport-specific skills. One aspect that we implemented into our program was a rehabilitation menu. The purpose of this was to allow the athletes some autonomy over their rehabilitation, to promote positive behavior and overall feeling towards rehabilitation. So what they did is an athlete would select an exercise from a range of motion, proprioception, strength and conditioning box. Each box only contained exercises from that box, and then they would pick one from each. The athletic trainer working with the athlete would pick one from each, and then they would go through all of those exercises. So to kind of put it in for phases that had more strengthening exercises, for example, the early recovery phase has a lot more strengthening exercises that we wanted to do. So for those phases, we allowed the athlete and the athletic trainer to pick more as being allowed. So this is an example of the rehabilitation menu. So at the top of the box, there's the basic patient information. So Jane Doe, anterior shoulder dislocation, log for early phase of treatment. So this is an example from the early phase. The injury date and the protocol author. So in each box, there's range of motion, strengthening, and proprioception. The athlete would then pick exercises. For example, I want to do exercises 3, 5, and 3. The athletic trainer would then also pick, okay, we're going to do 5, 9, and 1 then. In order to make sure that it was varied, the athlete wasn't just doing exercises that were their favorites and that they were able to incorporate all structures. Core exercises that we did for the core progression, we did include these throughout multiple phases of the rehabilitation program, so it wasn't just during the late recovery or the functionality stage. But these are some examples of exercises that we did: single leg, tandem stands, step-ups, lunges, quadruped and squats, and then unstable, stable surface. And then we progressed them just based on how the athlete was doing. More details on the exact progression can be found in my paper. The cardiovascular progression, as I noted earlier, the athlete needed to be able to maintain 60% target heart rate. So in order to, according to the Kerr-Bellman equation, so in order to compute that, you take your resting heart rate times 0.6 times home heart rate minus resting heart rate. So the simple equation max heart rate is taking 220 minusing your age. So for the athlete's case, we 220 minus 20 for a maximum heart rate of 200. So initially the athlete, we had them biking for 30 minutes every single day, just because they weren't able to do a whole lot of movements. And then once the rehabilitation program progressed and they were doing more things each and every day, we didn't have the type of time to monitor them biking for 30 minutes. So we kind of left it up to them to do cardio on their own, but we also, for 3 days a week, we would monitor and increase it to 30 to 60 minutes of cardiovascular activity, and more details on the progression can be found. Joint mobilizations we did were posterior glenohumeral glides, posterior humeral glides, lateral glenohumeral joint traction, medial lateral rotation, posterior humeral glides, and general scapular glides to promote mobility at the joint. So, in conclusion, a whole body approach is taken to rehabilitate the athlete and focus on cardiovascular, core, as well as the shoulder. We also incorporated psychological techniques to improve patient outlook on rehabilitation, as well as give them some autonomy over how their rehabilitation progressed. And the athlete was able to return to play the following season. Because of the time the injury occurred, 16 weeks post-op puts it within the first week of June. So the athlete actually left for the summer. So we told them to check in with their physician, continue physical therapy on their own. And then when they returned to school, we did additional testing to check in and see how the athlete had done through the summer, and allow them to return to play for their junior year. That's reference 1. Any questions?
Any range of motion restrictions early on?
Yes, we didn't want them to do full ranges of motion because they just had surgery and they were immobilized, so we kind of went to as far as they could until they experienced a large amount of pain, and would hold it there, come back down, depending on the range of motion, and then try to increase it each and every single day. But we never ever went above 90 for stuff in the direction.
At what point did you begin exercises above 90 degrees?
When I started doing strengthening exercises, so early recovery.
So they left for the summer and were out of your care. Were they allowed to play over the summer?
We did not address that with the athlete. We had not cleared them to play here, but we didn't clear them. We didn't discuss whether or not they would be playing over the summer.
Any brace for support when they return to activity?
No.
Nobody else?
Mine's a question on joint mobs. So since like the athlete was already super unstable, like post surgery, did the surgeon give you any restrictions for like he should wait a certain amount of time, or like did you have him strengthen first a lot before you like even started that?
We didn't do joint mobs right after surgery because of the instability. We were also really cautious of the anterior movements and then traction, especially, just being really mindful of that. So we waited until there was a baseline, or not a baseline, but some general strength, and then we weren't doing hard joint mobs. It was more just to promote some movement within the joint, because we didn't want to accidentally pull that out again. In short.
Sorry. Did you also do PNF?